Good evening. Thank you very much, Adam, and thank you very much, Rick. I've been asked to talk about the future of SOZO from a clinician's perspective. And I think most of you know that I'm a radiation oncologist, and as such, I've been causing lymphedema for many years. But it's really been only in the last 8 years since with Louise Colmeyer and Helen Mackey and later Hiruswamy and many others established the Alert Lymphedema program. And it's amazing what I did not know as a radiation oncologist before I started learning from all these very smart people around me. I'm also an author, and I'm currently writing a book on life after breast cancer taking control. And the lymphatic system, of course, is complicated. It's intricate. It's perhaps one of the less researched areas in medicine. But we know that when the small fine capillaries join the venules, you have this lymphatic system there, almost like a vacuum cleaner, picking up the pieces, draining proteins and waste products and helping almost be like a shock absorber to the surrounding tissue. And when it gets blocked, these fine lymphatics can easily become can malfunction after surgery or radiation therapy. And Professor Swamy has done these beautiful studies showing the normal drainage of the breast in green, but when we look at the arm, most of it goes to the armpit. But this pink area here that I'll show later is the cephalic pathway, which drains up around the armpit to the infraclavicular and supraclavicular fossa. And indeed, when we looked at a few hundred patients with who had an axillary dissection, we saw that 2/3 of the time patients still continue to drain to the axilla. 40% of the time they drained around this clavicular pathway to the supraclavicular and infraclavicular fossa, and then about 1 in 10 drained to the parasternal area, and about 1 in 20 to the contralateral axilla, and none to the inguinal area. And interestingly, if you read the paper, you'll see that as the stage of lymphedema increased, and particularly advanced stage 3s, there was more parasternal, contralateral, axillary drainage, but still no inguinal drainage. Lymphedema has an enormous impact on patients, and regularly have patients, and I know a lot of you do, in tears, saying that they can hide their mastectomy, they can hide this implant that's retracted after radiotherapy, but they can't hide this garment that they have to wear. And it's basically a daily reminder to themselves and to others around them, and that they've had lymphedema. But obviously weight gain, self-esteem are all issues. And I won't be talking about, of course, breast edema, which is a topic for another day. What I will mention, however, is that in this survey, partnering with the Breast Cancer Network Australia and Macquarie University School of Business, we discovered that lymphedema patients with breast cancer and lymphedema, was like a double whammy. And for all these domains, work, career, family, social, self-image, feeling about self, were always worse in the blue line for patients with lymphedema. What about radiation? We don't know why some patients get lymphedema and others don't. In this paper from my colleague Alphonse Tagian, who's done some amazing work using the pyrometry, and I had the pleasure of visiting him and giving a brief lecture at their centre, and looking and meeting their amazing staff. This very important paper showed that the peak lymphedema incidence was 6 to 12 months over here for patients who had axillary clearance. So this is the blue line, sharp increase in 6 to 12 months. But patients with sentinel node biopsy, regional node recurrence, was a lot later, 36 to 48 months. And you can see that when you look at these figures, that patients down the bottom here, 30% if you had radiotherapy to supraclav and axilla, developed lymphedema, and 25% with axillary dissection alone. But even patients who had a sentinel node biopsy and radiotherapy to the axilla was up to 12%. So it's important to understand the radiotherapy fields, try and get some insight from your patient, ask them did they get a sore throat, which is one of the clues that they may have had supraclavicular radiotherapy. Using old techniques, they often get a bit of sunburn just on their upper back, and that's another clue that you can ask them. And this is a diagram from Professor Swami again, a paper recently published this year, the all but forgotten Mascagni-Sappi pathway. This is in the setting of immediate lymphatic reconstruction using the lymphatic technique and reconstructive surgery. And you can see that the cephalic vein goes into the level 3 supraclavicular region, and it's likely that when we put on our radiotherapy supraclavicular field, we are damaging this alternate pathway. So the patient's getting a double whammy. They're getting the axillary pathway blocked with axillary dissection, and then the fluid may be draining the other way, and then we whack on the radiotherapy supraclavicular field. But it's a difficult area. Do we undertreat or potentially overtreat patients? But there's certainly patients who go into complete remission, perhaps after neoadjuvant Herceptin, that I may come off the supraclavicular field, but of course with informed consent. So what about the challenges for the radiation oncologist? It's really my patients' challenges. They're getting variation in advice about diagnosis of lymphedema and treatment of breast cancer. Access to therapists can be a problem. Being labelled as a lymphedema patient, do we say to somebody at 7.2 they now have lymphedema, 6.9 they don't? Do we call them subclinical lymphedema? And these are, as some of you know, that I have established screening programs, screening mammography in the past, and then we have the same issue that we have a technique that we screen everywhere, mobile vans, in shopping centres and what have you. And then if there's an abnormality, we trigger them, we assess them, and then if they have early breast cancer, we treat them. But for some of these patients, they have ductal carcinoma in situ. It's pre-cancer. It's not quite cancer, but we have that word cancer in the word ductal carcinoma in situ, subclinical lymphedema. And we've got to be very careful with our language and not to frighten patients, and obviously give them hope that by detecting it early, we can prevent it from occurring. Of course, there's patronising comments. You still hear it today. Look, we've cured you. Lymphedema is a small price to pay for your disease. Prevention of cellulitis, frequency of measuring lymphedema, weight management, and dealing with some of the myths. Can I have a blood pressure and injection, or can I fly, and so on. But the reality is, this week I saw 3 patients struggling. One had lymphedema, 2 didn't, but there's a whole range of other issues that our patients are dealing with, coping with the ups and downs, fear of recurrence, weight gain, sexuality. I'm not going to read them all out. And lymphedema prevention and treatment is just one of many issues that we have to deal with, and it's often difficult as doctors in a busy clinic bring some of these issues up. And one of my patients said to me yesterday, one of the few doctors who listens to me, listens to my concerns, and I think this is where therapists have an important role to play to move transition from lymphedema into exercise and other survivorship issues. And for the practitioners, lymphedema therapists, supporting preoperative access to get a baseline. How often do you screen them? How do you fit this into your busy week when you're trying to do MLD and laser and kinesiology and a whole lot of other things? Understanding radiotherapy, we've mentioned treatment after pathological complete remission. Can we adjust our radiation therapy? And of course, I did not know until 2012 that as lymphedema progresses, it deposits fat and fibrosis, and And really, in fact, your LDEX measurements can in fact come down as there's less fluid but more scarring and more fat when we introduce treatments such as liposuction. So the future direction, obviously, test, trigger, treat is a really simple approach that Impediment has come up with, which I really do like. Get a baseline if you can, screen regularly, and if it goes over 6.5, intervene, and certainly that's what I'm doing for my patients. And my patients do like looking at their charts and these longitudinal measures and empowering them. And I think SOZO and LDEX empowers the patient. And in fact, sometimes they realise it's not as bad as what they think when they're getting some symptoms. But there is a relationship between patients getting symptoms and the onset of abnormal LDEX. And I think I would rather have an abnormal in this particular patient. It used to be over 10 would be, self-report was a bit later, volume is a bit later, and you can see the difference between LDEX and volume is about 8 months. When you look at a pre-surgical baseline here, minus 4.41, we see a change occurring of 6.5 here. We would have intervened, my estimate is 22 months earlier. So this is the challenge. Do we wait for instruments like my clunky tape measure, inspection when I'm busy rather than getting the tape measure out, pyrometry, or do I rely on a more sensitive instrument like LDEX? And I'd rather pick up, particularly my radiotherapy patients where the lymphedema is occurring late, pick it up earlier using LDEX and SOZO. But is this all smoke and mirrors? Can a compression garment really help? And I know I'm teaching preaching to converted here, but I was really interested in this study, which was an ICG study. On the left here, you can see linear is the normal flow. Splash is maybe a bit dysfunctional, and you can see stardust where it's becoming damaged. Lymphatics with bridging and dermal backflow. Diffuse when there's a lot of dermal backflow and the lymphatics are totally disrupted and no flow at all. But you can see 196 patients before surgery that had the ICG, that there was a little bit of splash in 24 patients even before surgery, and maybe this is the future, picking up patients before before they have their surgery, and maybe this combination of ICG and LDEX may give us clues as to which patients we really need to intervene with compression garment pretty quickly after surgery. And you can see 35 patients here went into these orange and red and purple zones, and the protocol was if you developed stardust and diffuse on ICG, then you had compression therapy. And interestingly, 11 of 35, about a third of these patients had reversal of their changes with the therapy that you provide each and every day with compression garment, and so it can be integrated. As an example, this is a study I did with Professor Carolyn Lee from University of Western Sydney, where we surveyed patients from the BCNA cross-sectional survey. We found that the mean self-reported weight at diagnosis for patients with breast cancer-related lymphedema was 74 kilograms versus 68 kilograms. So this is not new, but it's an important Australian finding. So if we see a patient who's overweight, we know that we really should be thinking about these patients, not only monitoring, perhaps even treatment, modifying our treatments, perhaps erring more towards sentinel node biopsy and radiotherapy than axillary dissection. We know that 51% of patients were overweight or obese with a BMI of over 25 compared to 35% of women without breast cancer-related lymphedema. And if you had breast cancer-related lymphedema, you were more likely to gain weight. This was significantly different. And you're more likely to be currently overweight or obese and less active. And I call this paper Weight Gain and Lymphedema after breast cancer treatment, avoiding the catch-22. It's a real catch-22 that overweight patients get more lymphedema and patients with lymphedema gain more weight. And what we did find in a qualitative analysis is that having a structured exercise program, following a prescribed diet, and being accountable to someone else were some of the main facilitators to a successful weight loss program. And I would argue that integrating SOZO and the graphs and the feedback will be very important. And these are obviously some of the new outputs that of tissue analysis which can be integrated. So final couple of slides, current model of care, test, trigger, treat. I would like to encourage all of you to think of a broader model of care, and I have said this to Rick Carrion over a coffee or a glass of wine occasionally when I've met him when he's been out in Australia, is that go back to the blood pressure model. We had to go to the doctor to get our blood pressure checked. We then could go to the chemist and get your blood pressure checked, and then we could go and have our own equipment at home to get our blood pressure checked. So I would argue that lymphedema screening using SOZO should happen everywhere. It should happen at the chemist, at the therapist, at home, at the doctor, at the radiotherapy department. Increase the screening like we did with mammographic screening, and get it into the shopping centres. That, of course, should be monitored by a therapist. And that therapist, once the number is abnormal, should see that patient. And that accredited therapist should not just be looking at lymphedema, but looking at their exercise, their diet, menopause, sexuality, body image. I'm not saying alone, but in combination with their GP, the doctor, other therapists, psychologists, and exercise physiologists. More sophisticated tests should occur with the accredited therapist, not just the SOZO. It might be the moisture meter, it might be interpreting body composition, referring or doing ICG, or looking at their shoulder, breast edema, pyrometry, and then intervening with ICG, directed SLD, all the other conservative treatments that you know a lot more about than I do. And of course, understanding when early surgery should be done with LVA, lymphovascular anastomosis, or lymph node transfer, or when to intervene, when to say, look, I can't do any more because of the fatty fibrosis, and intervene with liposuction, and maybe one day medication. Thank you very much for listening, and thanks once again to ImpediMed for your very kind invitation.